Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about acute sinusitis. That's responsible for about 30 million office visits to primary care physicians every year in the United States. Your likelihood of developing acute sinusitis is about 1 in 12. It's about the same frequency as asthma. It's more common than hay fever. And on average, people will lose about 5 days from work or school every year because of acute sinusitis. And it's the 5th most common cause for people to receive a prescription for antibiotics. Not that they really need it, but that they're going to get it. Now, this is a condition where we have inflammation of the mucosa lining both the nose and the sinuses. The mucosa that lines these cavities, the nasal cavity and the sinus cavity, is continuous. So if you're going to get inflammation in one area, you get inflammation in both areas. That's why the proper name isn't sinusitis, it's rhinosinusitis. The sinuses themselves are paired cavities. They're cavities or air cells. They're both on the right side and the left side. They're within the bones. And you have the frontal sinuses. They sit above the eyes and the forehead. You have the maxillary sinuses above the incisor teeth. In the maxillary bone or the upper jaw bone, you have the ethmoid sinuses between the eyes, and you have the sphenoid sinuses behind the eyes. The purpose of the sinus is to lighten the skull, to improve the voice, to protect the nose and protect the nasal cavity from pollutants and microorganisms and dust and dirt, and to provide some moisturization for the nose. Now, the maxillary sinus, as an example, is about 1 inch across. That's the largest sinus. It holds about a tablespoon of fluid, and it has an opening that only is about 1/10 of an inch in diameter, and it happens to be at the top portion of the sinus, not at the bottom. So when you're standing upright, your maxillary sinus is not going to drain. The frontal sinus develops later in life. It develops when you're about 6 or 7 years old. Doesn't show up on an x-ray until you're about 12 years old. The sinuses drain into the nasal cavity. The sinuses are lined with what we call ciliated pseudostratified columnar epithelium. What that means, that's fancy medical jargon, for it's got some little hair cells, it's got some goblet cells that make mucus so that they can form some mucus material that'll trap the toxins or the particulates. And the hair cells are important in moving the mucus out through the sinuses, through that little teeny-weeny ostia, into the nasal cavity, where you can then either swallow it or it can come out of your nose when you blow your nose. Well, the important thing is that when you develop a viral infection, when you develop a common cold, there's some swelling of all of the tissue inside the nose. And when you have swelling of the tissue and the opening of that particular cavity, let's say, is only about 1/10 of an inch in diameter, you can see that it might swell so much so that any of the bacteria that happen to be inside the sinuses are stuck there. And they just keep on growing. And when they grow, then they can cause some mischief. And then you can get the bacterial sinusitis or rhinosinusitis. So most of the time the situation starts off with just a plain upper respiratory infection, a standard viral cold. Symptoms are going to peak rapidly. They peak after about 2 or 3 days. And for the most part, people are going to get better without any kind of intervention, without any kind of treatment. They get better in about a week. But sometimes the symptoms last a little bit longer. And sometimes you run to the doctor because what happens is that your otherwise clear mucus now all of a sudden becomes green or yellow, and you assume that that must mean that you have a bacterial infection. That's not actually correct, but that's what most people believe, and that's when they think that they need to go and get some antibiotics. Now, the signs suggesting that all you have is a viral upper respiratory infection, coughing and sneezing and a runny nose and a sore throat, maybe some nasal congestion. Symptoms peak, as I mentioned, very rapidly, go away. You can't tell in the early stages whether you just have a viral upper respiratory infection or if you have a viral rhinosinusitis. The important thing to realize is that there is no easy way to differentiate the viral syndrome, the viral cold, the viral upper respiratory infection, from the viral rhinosinusitis, just the virus causing all the problems, versus the bacterial rhinosinusitis. So if you seem to go for more than about 10 days or so, and if you seem to get worse instead of better, or you initially seem to be getting better, and then all of a sudden you got worse, then you have a fair chance of having some bacteria present. Now 90% of the people, 90% of the people who have just a simple cold are going to have a viral rhinosinusitis. So just because you have a sinusitis or a rhinosinusitis doesn't mean you need to run to the doctor. As a matter of fact, even when you have a bacterial rhinosinusitis that's a complication of the virus that occurs in about 0.5%, well, as the virus subsides and as the swelling subsides, then the opening can reopen and then it can drain itself and you can get better even though you had a bacterial rhinosinusitis. You get better without having to take any antibiotics. So the differentiating point between just a viral cold and rhinosinusitis, either because of the virus or because of bacteria, is the presence of purulent nasal discharge. So you have to have some pus. And that's why the color forms, because the white blood cells change the color. So it changes the color to a yellow or to a green, and it's thick and it's opaque. And you can see that if you look in the back of your throat, you can see some of the pus, or you can see where the sinus cavity enters into the nose. You can see some of the abnormalities, but there is no simple symptom that's going to differentiate the plain viral rhinosinusitis from the bacterial rhinosinusitis. You need the presence of some discoloration. So without that, it's just a viral upper respiratory infection. If the signs and the symptoms seem to go away, then you just had a viral rhinosinusitis. If the symptoms don't seem to go away and you have the pus, then you probably have a bacterial rhinosinusitis. So rhinosinusitis starts off as a common cold, then you get the viral rhinosinusitis, and then sometimes 0.5% of the people are going to have an infection inside the sinuses, and that's the double sickening, and that's when you should perhaps consider going to the doctor. Not just the presence of the colored discharge, but it's the persistence of the colored discharge and the presence in the back of the throat or the presence in the nose. Now, the presence of that colored pus, remember, does not differentiate the viral rhinosinusitis from the bacterial rhinosinusitis. So just because you have the colored pus does not necessarily mean you need to have an antibiotic. If you only have the obstruction and you don't have the purulent discharge, the colored pus, then you don't have rhinosinusitis. If you have facial pain but you don't have the purulent discharge, you don't have rhinosinusitis. With rhinosinusitis, whether bacterial or viral, you can lose some sense of smell, you can have some ear fullness and some pressure, some sensitivity or facial pain or pressure. Often it gets worse when you bend forward. Sometimes it can radiate into your teeth. Acute rhinosinusitis lasts by definition less than 4 weeks. It becomes chronic if it's more than 12 weeks subacute in between. And you can have multiple episodes during the course of the year. It's also important to realize that the etiology of all of this, the cause for all of this, tends to be a simple virus, a rhinovirus, an adenovirus, the influenza virus, parainfluenza virus. And the 3 key features seem to be the sinus mucosal edema, or the swelling, because that's the swelling that's going to obstruct the drainage from the sinus into the nasal cavity. So that's point 2. 1, we have the edema. 2, we have the obstruction. And 3, those cilia, because of the respiratory infection with the virus, those cilia that are supposed to sweep the mucus from the sinus cavities into the nose, those hair cells don't seem to work very well. And when they don't work very well, then we have the stagnation inside the sinuses. Now, 85% of the people are going to get better by themselves without taking any antibiotic. But the converse is that 85% of the people who go and see a doctor are going to probably get an antibiotic that has very little chance of helping. So why do you get the mucosal edema? Well, it's usually because of the preceding viral respiratory infection, but it might be because of allergic rhinitis, or it might be because of vasomotor rhinitis, or it might be because of some kind of an obstruction, maybe a deviated septum or nasal polyps, or maybe you've had some trauma, or maybe you have a tumor, or a foreign body is in your nose. And sometimes it might be because you've had some work on your teeth. Work on your teeth, because remember, the teeth sit right below the maxillary sinus. Or it could be because you had some sinus surgery, or you had a nasogastric tube, or you had some nasal packing, or maybe you have some immunodeficiency and it prevents the body from getting rid of the bacteria. Maybe it's because you have HIV, or maybe because you have some kind of immune globulin deficiency, or maybe you have impaired ciliary motility. Those hair cells might not work right because you're a cigarette smoker. Maybe because you have a condition that we call the immotile cilia syndrome, or maybe it's because you have asthma or allergies, or maybe you're just breathing in the cigarette smoke from your neighbor or your spouse. Well, usually when we do find a bacterial infection, it's due to the organisms that are typically present in the nasal cavity, in the upper digestive cavity. It's the strep pneumonia, it's the Haemophilus influenza, it's the Moraxilla catarrhalis. Those are very common organisms that are present. It tends not to be anything really fancy, at least in those people who just have a single obstruction or a single problem with the bacterial infection. Now, children can get the problem just like adults can. When the children get it, they have the nasal obstruction and the blockage, and they have the colored discharge, and they tend to have a cough that lasts both day and night. Pregnant women can get a type of rhinitis that can mimic rhinosinusitis. And in these individuals, because they're pregnant, we call it the rhinitis of pregnancy, and it's due to the vascular engorgement. Now, here's an interesting situation. Most people believe that when your sinuses become inflamed and infected, that you could develop a sinus headache. But that's not a recognized disease. Actually, people who think they have a headache due to their sinuses, even people who are self-diagnosed, or people who go to see the family doctor or the ENT doctor or the neurologist, and they come away with the idea that they have a sinus headache, they're actually mistaken. What they probably have, in more than 90% of the cases, is they have a migraine headache. And the migraine headache symptoms closely mimic those of rhinosinusitis. They mimic the migraine headache, or sometimes a tension headache, or sometimes a variety of other problems where you can have the pressure in the sinuses and pain in the area of the sinuses and nasal congestion and even a watery discharge. That's extraordinarily common. In addition, people who have migraine have a variety of other symptoms as well. They can develop a grittiness of the eyes and some facial flushing and some eyelid edema and redness of the eyes, and all of those very common. But it's migraine headache, it's not a sinus headache. Rarely we can have infectious complications. Once upon a time, back before the advent of antibiotics, when we had a completely different kind of culture, different kind of bacteria, and we had less hygiene, well, people would get some complications. Now, the complications, the infectious complications, are exceedingly rare. And the incidence of serious complications is less than 0.08%. We can develop cellulitis, or sometimes problems with eye muscle movement, or sometimes altered sensory state. Orbital complications and neurologic complications have been described, but extraordinarily unlikely nowadays. When the problems in the neurologic realm begin, they tend to occur mostly in people who are relatively young, in their 20s and 30s, occur much more commonly in men than in women, and tend to involve the frontal sinus. But those are the exceptions, with the meningitis or the abscess Not very common at all. In the pre-antibiotic area, saw these problems, not anymore. The problems seem to be due to bacteria penetrating through some valveless veins into the bone, or a release of septic emboli. And that's not an issue anymore. Laboratory tests to differentiate between viral rhinosinusitis and bacterial rhinosinusitis. Nah, we don't really even have any good blood tests for that. There's the SED rate and the C-reactive protein. They're pretty useless for the purpose. How about a plain X-ray? No, plain X-rays don't really give us that much information. We could do a CAT scan, a CT scan of the nose and the paranasal sinuses, but we reserve that when we think that there might be a complication, maybe a non-infectious cause, or a complication with the orbit, or maybe a person has diabetes and can't handle infections well, or maybe the person's had surgery, or maybe the person's taken antibiotics and failed treatment, or there's the thought that maybe the person might have malignancy. Then good idea, get a CAT scan. On the other hand, the signs of inflammation or infection inside the sinus cavities aren't really spectacular with CAT scan. It seems like a lot of things cause the same opacification of the sinuses, the air fluid levels, the thickening of the mucosa. And a CAT scan isn't really all that much better or different or provides any more information than the clinical examination. Well, so what do? Well, we look for some red flags. And red flags mean that you should see the doctor without any kind of question. So if you have rhinosinusitis and all of a sudden you have a stiff neck, or when you look into the lights it seems to be especially bothersome, or you have an altered mental state, yeah, you ought to see the doctor. If you have frontal swelling, or if you have double vision, or it hurts when you look out, yeah, you ought to see a doctor. Well, what should you do for just treating a simple viral upper respiratory infection, or viral rhinosinusitis, or bacterial rhinosinusitis? Same kind of treatment for all of the conditions. Common sense, of course. If you're a smoker, stop. Adequate hydration, make sure you're taking enough liquid so that the mucus can become hopefully somewhat more watery. A humidifier or vaporizer may well be of some help. If the problem is some pain, well, some analgesia, some aspirin or similar product, you can irrigate the sinuses with some normal saline. You want to ensure that the saline is sterile, so you don't use tap water. You could use some distilled water, or you can buy a variety of preparations available over the counter. A nasal decongestant might help. Mucolytics, probably not going to help. Antihistamines, probably not helpful. Intranasal steroids, Flonase, and medicines like that, well, they can sort of reduce some of the swelling, so they might be helpful. Cough suppressants like dextromethorphan, probably not going to be very helpful. And expectorants like the guaifenesin, that might be somewhat helpful. The antihistamines might cause actually some problems because they can dry everything up. And remember, you want to hydrate the area. Decongestants like Afrin could be used for a couple of days to shrink the mucous membranes, and that has a tendency to open up the ostia so that the sinus cavities can drain a little bit. And especially if you follow opening of the sinus cavities with decongestant that you could use for the 3 or 4 days, if you combine that with the use of some of the nasal irrigation, that seems to be pretty helpful. The nasal irrigation with the Neomed or the Netipod or the ocean spray or the saline sprays, they all seem to benefit most people. Is it a home run? No, it's not really a home run. But again, remember, don't use tap water. Use a hypertonic saline. Most of those come appropriately prepared, or with Neomed comes with little packages of saline that you enter into or dissolve into a set amount of liquid. The mucolytics, well, they're probably not very helpful, but watchful waiting is the way to go. We just wait it out. And usually, within 7 to 10 days, you're going to get better. And you don't need any kind of medical therapy, and you don't need any kind of intervention. And as a matter of fact, for the overwhelming majority of people, the medicines that we have aren't probably going to be all that effective. If you have any complication, obviously you want that treated. Question is about antibiotics. Well, antibiotics are thought to help about 5% of people. That's right. Of all of the people treated for acute rhinosinusitis of potentially bacterial origin, the antibiotics are going to help only about 5% of the people. They're not all that much benefit to using the antibiotics. And as a matter of fact, if we compare the antibiotic therapy to placebo therapy, it's kind of a wash. We need to treat about 18 people to get one person improved with antibiotics, but we only need to treat about 8 people to have one who has a side effect with an antibiotic. And interestingly, the antibiotics don't seem to be associated with improvement as far as pain is concerned or the duration of the symptoms are concerned. So don't rush out and get an antibiotic. But if you do need an antibiotic because you're not getting better and you do have the discolored mucus, then the question is, how long should you take the antibiotic? Most people have always said, well, you take a 7 to 10 day course. But actually, if you took a 3 to 7 day course, or say a 5-day course, that would be every bit as good as a 10-day course, and it would reduce the incidence of complications by about 20 or 30%. So a short course of antibiotics if you're going to take the antibiotics. Who should take the antibiotics? Well, people who fail to respond, or if we suspect that you have some anti-resistant or some antibiotic resistance, or if you have a problem with your immune system. So typically, the major candidates would be children less than age 2 or older people over age 65, people in daycare centers, people who have been treated with methicillin, or people who have been hospitalized within several days or had recent sinus surgery. The choice of antibiotics, amoxicillin, probably is the first choice, or if there's a suspicion of resistance, then augmentin. But if a person's allergic to penicillin, then probably the choices would be doxycycline or one of the sulfa drugs. Tend not to use Cipro, that's very popular. Tend not to use the Levaquin, again, that's very popular. And the Z-Pak idea, get over it. That's not really helpful. Shouldn't probably take that kind of medicine for acute sinusitis. Now, surgery. Is that the answer? Well, let's say a person has recurrent episodes and you have surgery. What's the likelihood that you're going to have an attack in the course of the next year? Well, it's probably reduced, but it's reduced by only about 50%. So if we look at people who have multiple recurrences of long duration, maybe consider surgery, but don't expect any miracles from surgery. And as far as the vaccine is concerned, you've heard about the pneumonia vaccine. Well, it's a strep vaccine. So does it help the strep that grows in your sinuses? And the answer is probably not very much so. So if we look at the era before the vaccines, the strep pneumonia accounted for about 46% of sinusitis. After the vaccine, about 35%. On the other hand, the strep that does grow in the sinuses tends to be resistant to the antibiotics, and taking the place of the slightly reduced incidence of strep, we have an increased incidence of Haemophilus influenza, which is another very common bacteria. And it also tends to be resistant. So the best thing to do for the overwhelming majority of people, if you do develop a viral upper respiratory syndrome, or if you develop a viral rhinosinusitis, or if you have the complication in 0.5% where you get a bacterial rhinosinusitis, all of which can have similar symptoms. And remember the differentiating fact between the viral syndrome plain, just the cold, and the rhinosinusitis is the discolored mucus, or the presence of the pus that's in the back of the throat or in the nose. And for those people, it might be appropriate simply to wait it out. And if you don't seem to be getting better after a reasonable period of time, then the doctor can evaluate the situation to see if an antibiotic is appropriate or some other kind of therapy that we mentioned. So that's really the story about sinusitis or rhinosinusitis. Very common condition, but unfortunately, often treated incorrectly. Anyway, thanks for watching. I'm Dr. Ken Landau.